Good morning, just waiting for some more participants to join. I can see the numbers going up. Okay, why don't we get started? We have a smaller audience today, it looks like 64 patients, because 64 attendees, because I have a non-COVID topic. So I'm going to start with well, first let me tell you the ground rules. The audience is muted. Only the panelists will have audio and video. So you will not be able to speak or display yourself. If you need CME, the only way to get it is to send in your evaluation forms to Lisa. So please try to do that in any case, because I like to hear what people think about these presentations. There really are no COVID updates today. I would direct people to the toolkit, because there's some new information on serology and how to use serologic testing. The indications are actually quite limited, but there's some nice information on there. We are now able to order the antibody test if we think it's clinically indicated. So that is something people should go look at. So let me do a quick poll here to see who's in the audience. So if you would punch your responses. Okay, and so these are the results. We have, okay, mix of people, specialty physicians, some primary care docs, a few hospitalists, a few residents, 3 residents. All right. I do have a second poll question, and I might show this again next week. So typically our grand rounds sessions will end after the middle of June. I was thinking this year with COVID going on, we may want to do some updates. So of these 3 options, hold further grand rounds until September, maybe do 1 update in late July versus do a COVID-19 update every 2 weeks versus do a COVID update every 4 weeks. What would you want? And the poll is now on. Okay, 85% say do it every 2 weeks. That's probably what we'll do. I'll take this poll again next week when we actually have a COVID-related grand rounds. And with that, so this is our monthly staff meeting and resident case conference. So we're going to start with Dr. Alag with a health informatics update, and then we'll move on to our case. So without further ado, Dr. Karan Alag.
Hi, good morning all. Thank you for the opportunity to come in with the quarterly update. Last time we did this update, it was in end of January, and it was a different world. Slowly we are inching back to the same old times. So the updates I have is the same format. We'll introduce a couple topics, recent updates. There's a message of the quarter, communication, how to get to HI. We did have a quarterly upgrade on May 21st. I'll go through those details, a few examples of those, and then we'll open for questions. So introduction topic, we have clinical informatics, clinical informatics team. So clinical informatics is the application of informatics and information technology to deliver healthcare services. Our team currently consists of 1 manager, Jan Erickson, and we have 5 clinical informaticists who staff and manage 27 advisory groups across various specialties and 3 advisory committees. They do help us with bridging clinical and operational users, inter-advisory group communications, help us to prioritize changes and updates. They do coordinate between the advisory committees and advisory groups, and also help in cascade information both ways to the IT and also back to clinical folks. So these are the team members. Wanted to introduce them, and if there are questions, you can always reach out to them and participate in advisory groups. You'll see them in person. The other topic I wanted to introduce is the BCA process, which is business continuity access, or what we call as downtime. Downtime processes are at different gradings. They go from decreasing severity from A to C. A is when network or power is affected. There are certain computers on each medical floors and offices which are still operational. C is the small freeze, like an upgrade freeze, where you have downtime for a few hours where changes are being made. You still have access to the environment, but it's not read or write capable. So these are the A, B, and C downtimes. What changed now is we also have downtime order sets now. Like when we provide clinical care, we are so used to using order sets. So during downtimes, we can have the same order sets available in printable format and provide the same care even during downtime hours. How do we get to downtime? These are the downtime reports on downtime computers. They do have a B next to their names, and each floor has one. If you ask the secretary or charge nurse, they can also guide you. Once you log in, going to reports, you can search the entire department and find patient reports there. In addition, the common use order sets are underneath, which can be printed out. Again, so for example, if I'm going to 5800, I log in, I can print an order set, and it allows me to print the entire order set for that patient, and I can check and do the paper marking. So then later on, these could be transcribed into electronic format. Recent updates, predominantly the update had been COVID in the last quarter, March and April specifically. They were almost 450 plus RFCs and still counting. We had a priority review of those 3 times a day, and emergent bills, a lot of changes went through. There was expansion of telemedicine in multiple formats, both outpatient, specialty, inpatient. Interoperability of COVID-19 results. We are able to bring results from outside RRH, including many other counties from New York State. We have a lot of COVID-related analytic tools and abstraction for research reporting. There are tools for training, clinical decision support, COVID-related, how to order test, questions associated with testing, billing codes, diagnosis codes. All these updates happen on the back end to make it seamless to provide care for a new diagnosis, which never even existed before February in our systems. Surge and capacity planning, where med-surg capacity and ICU units were built. Security templates to provide staff, so it's easier to redeploy in different areas and have all the tools available. Ventilator device association to know which patient is on which ventilator when the need arises. There were analytic and reporting upgrades like slicer dicer, benchmarking, COVID pulse reports, COVID click dashboards. Power mic licenses were expanded. 250 plus licenses were added for ED providers and inpatient providers. ED providers specifically because of scribes not being able to work anymore during this COVID times. Datos, we partnered with Datos Health to efficiently monitor patients who were going home to have a remote monitoring of their symptoms and progress and stability. Haiku mobile access for nursing leadership who are more mobile so they can be in touch with communication. Haiku is a tool for providers where we use messaging in addition to patient care that was allowed for nursing leadership as well. In other updates which happened, which are non-COVID related, we had a quarterly upgrade on May 21st. I'll go through a few example changes which went through later in the presentation. Unplanned readmission predictive model went live. which care managers are using and social workers are using now to help prioritize their work and predict which patients may be coming back. I'll come on more details on the next update. UMMC went live between our last quarterly upgrade on 2.1. It seems like a long time ago now. There are system knowledge builders like Advanced Care Planning, ACB Navigator, which is accessible from Storyboard, which is one stop shop for all moles, e-moles, surrogates, smart phrases, and many other changes went through. Upcoming events, further expansion of video visits, exploring additional predictive analytic models, and HIM7 recertification, and the work keeps on going. Message of the month, video and telephone visits. The way we have transitioned, if you look at this trend, when we started, we had predominantly face-to-face visits. But if you look over a few weeks down the road, many more telephone and video visits have taken place of it. And this has happened in both PCASI outpatient and specialty medical group. What's also outstanding is that between these groups, let me see if we can. Between the two groups, the satisfaction has stayed on. This is from the patient survey, and the satisfaction has been still at more than 80–90%. If you ask them how was it timely, any difficulty, whether using a smartphone or a desktop, and how was the satisfaction score, it was still preserved across these platforms despite the change. The second message is that we have a CIDR which is being scoped towards EMR request optimization or RFC process. The introduction here is that we are looking towards creating a transparent, predictable, and efficient process for managing EMR optimization requests. Our goal statements are transparent for stakeholders, a process which is easily understood, decisions are clearly communicated, and status is easily accessible. It's an efficient process where it's prioritized and vetted based on clear defined criteria and predictable outcomes where quick wins and high outcome and quick changes are prioritized and which meets business needs and stakeholder expectations. So this is being scoped right now. The feedback I would want from the group is, do these goal statements meet the need towards what we would like to achieve with this request optimization process? Communication with health informatics, Strides went through a new format. This was a request that when Strides comes out, having it role-based, so we can easily click on the role what we are, and then we can have our changes specified. So this was made, and it has been so far well received. If you have not seen the Strides, I would suggest please open your Strides email and try to use those. All these links launch you to your role and changes which are put into your role. You can see them by topic in the bottom, and that can show you all the roles as well. How do we communication with health informatics, accessing KBs? These are available on the portal or from within Epic. If you go to the Epic bar, internal links and knowledge builders, that is where we also have Care Connect COVID toolkit. This is Care Connect part of the COVID-19 toolkit, and also the nurse redeployment packet. But this is where all the knowledge builders and education material as they are being rolled out are placed. You can review those, and if there's any feedback, please provide back. Coming back to the May quarterly upgrade, the upgrade which went through just recently, what all changes went there? The few examples, note summary. Now in every note, clinicians can write a plain text summary within 150 characters on the top of the note. If you see on the top, there is a summary box there. What it does is it shows up on the top of the note display, and it can be a quick summarization of what the note contains. Or it could also be a communication between clinicians what I want to communicate about this note or this encounter. These are also searchable. When I go to chart review in the notes, there's a little icon which comes up. And as I hover over, I can quickly see the summary. So it can help me choose which note I want to read in detail. So that's something we can start using. When we have tables pull into notes, these are adjustable. So we can format them based on the note size and the rest of the text. Duplicate procedure warnings. When we use order duplicate test, we get a procedure warning. Now we get two things with it. We get the last results. In addition, we get any existing orders to decide, do we need a second one? This is especially important if we're ordering tests like once in a lifetime genetic testing or things you would not want to repeat. You can see the results there, and if it's available, we probably don't need to order them again. Manage orders, they have a gray background for anything which is being held or completed or expired. So this is a change to clearly identify. The last doses shows up under the bottom as what happened with the last dose. If it's in progress, it's expired, or it's complete. There are new icons available on Storyboard next to the patient's name. The E is the Care Everywhere, which shows that there is more information available from other Epic organizations. And there is a little folder which is for reconcile outside information. If that patient has additional information from outside records, clicking that would take you to the screen where you can reconcile them easily. Attestation notes, this has been another change which was requested. While attesting note, we could not edit the note which is being written. So now there is a little pencil icon on the top. So say if I'm attesting a resident note, and if I don't agree with a certain change, I can click the pencil and make the change in the note itself and do my attestation in the bottom and then sign it. So from one screen while you're attesting, you can also edit the original note to make it accurate in content. Another feature which was long desired, secure chat. There are times when you want to send a message to another person and you have to type it all over again. So now we can copy that. It can be done from mobile platform or in hyperspace on the desktop. When you copy in a mobile platform, you can only paste in the same patient's chart or in the same patient's message. So this is a feature which is available now. For outpatient providers who use Care Connect in their offices, the color scheme of patient's status, whether it's a no-show or came in, the color scheme matches your mobile platform, whether it's a Haiku on phone or Canto on tablet, with the desktop colors, so it's makes it seamless. Phones, Apple phones, iOS phones, which have a larger screen now, if you can make them landscape and have a broader view of activities. In addition, you have a list, you can have a two-pane view where you can select the notes on the side and have a preview on the side versus just having it in the regular standing fashion. Patient reminder messages are available in Haiku and Canto. So this is used a lot in outpatient setting where reminder about when something needs to be followed up or a test needs to be ordered. These can come into your mobile as well. Other mobile updates, isolation orders on patient list view. So if a patient has isolation ordered, on the patient list, there are new icons which show up demonstrating that the patient is in isolation. Similar names now appear bold and in italics on mobile as well. Android can see media images which are scanned in. iOS devices already had that. Mobile push notifications turning off doesn't affect hyperspace notification, so those can continue on. And anytime we're doing secure chat and a participant leaves the conversation, that does not appear as a new message, so less alerts and less interruptive alerts. Action items, identify downtime computers in clinical areas so we are aware in case we need them. EMR request optimization project, the goals we did discuss. If there are any other feedback or any other goals you think we should be incorporating, please let us know. Go through the knowledge builders, and these are the contact information for clinical informatics team. The downtime order sets Dr. Nasser. COVID RFCs, Dr. Alcantara, patient engagement efforts, Dr. Stratton Smith, and the new strikes format, Katie Melrose.
All right, thank you. So while I'm putting my slides up, I'm seeing absolutely no questions. So we must have had a crystal clear presentation because nobody has a single question. There was one thing I was going to bring up though with the televisits. We had talked about this in our division lead meeting earlier this week. It seems like different people are using different platforms. I know MyCare video visits are being encouraged, but they're not as effective as some other mechanisms like Zoom, et cetera. So it would be good if the system would come up with a non-MyCare recommendation for folks to use if MyCare does not work.
Definitely. There is a knowledge builder on non-MyCare video visits on how to use and what to do with it.
But is there a preferred option of the different ones there are?
Preferred is still MyCare, and as MyCare sign up builds on, I think that would become more promising. With each upgrade, MyCare is becoming seamless. But Skype is preferred. Skype is which has been approved, and I can forward over the knowledge builder along with these presentations.
All right. Sounds good. Well, we'll move on to the case. So Dr. Manasi Godbole is one of our graduating third-year residents, future hematologist. She will present the case.
Thank you, Dr. Phatak, for the information. So welcome everyone to Grand Rounds. This is my first experience on Zoom and it feels great so far. So we'll get started, and this very first slide that you see here, I'm dedicating it to Dr. Bernstein and his memory here with us, because he always used to start case presentation with something like her story begins as follows. So let's get started. So the patient we have today for presentation is a 72-year-old female who presented in June of 2019 with complaints of nausea and abdominal discomfort to the emergency department. As a part of the workup in the ED, she underwent CAT scan of her abdomen and pelvis, and that showed a renal mass measuring about 4 into 3 into 2 centimeters in the inferior pole of her right kidney. She was then also subjected to further blood work. But before that, we'll go into some of her history. So our patient has a past medical history of hypertension, osteoarthritis of her knees, and GERD. Her past surgical history includes cholecystectomy, a recent left total knee arthroplasty, and a cataract removal. She doesn't really have any pertinent family history, and she admits to occasional alcohol use, but never smoked or used any recreational drugs in the past. Her medication list includes amlodipine for her blood pressure, dexlansoprazole or Dexiland for her GERD, metoprolol succinate, PRN Miralax for constipation, and ibuprofen for her knee pain. So as we can see here, the reason I put this slide was because a few months ago when her blood work was done for regular routine clinical workup, her baseline was noted to be around 0.88. And when she presented here and was noted to have the renal mass, her creatinine had jumped up to 1.9. During this ED visit, this AKI was thought to be pre-renal given her nausea and poor PO intake, and it surprisingly resolved with IV fluids. She was then discharged home and was planned for an elective right nephrectomy in the future. Surprisingly enough, within a month, on July 18, she returned after her preoperative blood work showed rise in her creatinine from the 1.9 before to 4.8. And during the similar presentation, she also started complaining of having worsening of her appetite and increased thirst and urinary frequency. The review of system during this presentation was notable for fatigue, chronic cough and baseline shortness of breath, some constipation, chronic left knee pain, but most notable for increased urinary frequency, polydipsia, and generalized weakness. The physical exam revealed vital signs of 120/71 millimeters of mercury of blood pressure, heart rate of 61 beats per minute, respiratory rate of 18 per minute. Her temperature was 36.2 centigrade, and she was breathing 98% on room air. On constitutional exam, she was awake, lying comfortably in bed, and in no acute distress. Her physical exam only revealed right flank tenderness, but otherwise was unremarkable for respiratory, cardiovascular, or abdominal exam. Initial lab values were notable for a mild anemia with a hemoglobin of 10.1 and hematocrit of 32. And the BNP, as we can see here, was strikingly different on two comparisons, with drop in her bicarb to 19 and an increase in her creatinine level from 1.17 on the day of discharge from ED to 4.7 on the presentation again. And she also had a urine analysis done, and that surprisingly showed 2+ urine glucose, 1+ blood, 2+ protein, and leukocyte esterase of 1+. We also have to keep in mind her glucose on the previous BMP was normal, but she had glucose in her urine. The next day, there was a spot urine protein to creatinine ratio performed, which came back to be about 2.2 grams per gram of creatinine, and nephrology was consulted. So I'm going to hand over the presentation now to Dr. Grieff to continue here forward.
Thank you, Dr. Godbole. Good morning, everybody. So any examination of acute kidney injury starts with an examination of the urine. And in fact, the origins of urinalysis started 6,000 years ago. And in fact, urinalysis was the first form of laboratory medicine. This continued into the Middle Ages, the Renaissance period, and there are many paintings of early physicians examining the urine. Hippocrates even knew that a foamy urine may indicate that somebody had kidney disease. And as well, a darker urine would suggest the ongoing presence of fever. And it wasn't clear at the time if he meant that what was meant by this as the patients were getting more septic and ATN, or were having pyelo and infection. Next slide. There are many special things in urine, and urine has been used, and in fact, this is a painting of Hennig Brand, who first discovered phosphorus. And he discovered it by trying to convert urine into gold. And he collected 1,500 gallons of urine to find phosphorus. More recently, VEGF, vascular endothelial growth factor, was purified by Judah Folkman, and he actually found it by isolating it from gallons of mouse urine. Next slide. So when we look at the urine, we start off with a gross examination of the urine, this being a somewhat cloudy, bloody appearing urine, which can mean many things. Next slide. But for a more precise examination of the urine, we actually resort to a urine dipstick as well as microscopy. And in the dipstick, we'll be looking at for blood in the urine, leukocyte esterase, nitrite protein, pH, specific gravity, and glucose. But often when we analyze somebody for acute kidney injury, we're looking for whether there's blood or protein in the urine. Now, it's important for the residents and trainees in the audience to realize that there's certain keys to the urine that always come up on exams. One is that a red to brown urine can be hematuria, but if there's no sediment, it can be myoglobinuria or hemoglobinuria or unusual pigments. As well, just like Hippocrates noted, frothiness of the urine suggests proteinuria. And then we resort to microscopic examination of the urine, where we look for cells, casts, and crystals. Next slide. There's specific urinary patterns associated with different forms of kidney disease. Hematuria with dysmorphic red cell casts, and varying proteinuria suggests a proliferative glomerulonephritis, a nephritic picture. Heavy albuminuria with minimal or absent hematuria suggests a nephrotic picture suggesting a non-proliferative glomerulopathy such as diabetes, amyloidosis, membranous, focal sclerosis, or minimal change. Multiple granular and epithelial cell casts and free epithelial cells suggest ATN. Isolated pyuria could be infection or interstitial disease, interstitial nephritis. And normal urinalysis is much less specific, and it's much more difficult. If acute, it could be ATN. If subacute, it could be pre-renal, obstruction, hypercalcemia, interstitial nephritis, myeloma, cast nephropathy. Next slide. Our patient's urinalysis was interesting. It showed 2+ protein, blood, and 2+ glucose. There were granular casts with a few red cells, but no dysmorphic forms. Next slide. So let's look at the renal glucose handling, because that was used as a clue and to help us direct our differential diagnosis in this case. In terms of renal glucose handling, as we heard last week, the proximal tubule reabsorbs all filtered glucose. We do not have glucose in the urine until the glucose reaches above 180. And why is that true? Next slide. There are molecular transporters in the kidney, in the proximal tubule, which are responsible for glucose reabsorption. So glucose is freely filtered. It's a very small molecule. And then 97% of it is reabsorbed by the transporter that's called the sodium glucose transporter, SGLT2. There's another transporter called SGLT1, which is nowhere as important. It reabsorbs 3% of the glucose, and it's kind of like a scavenger in all this. But by the time we urinate, there's no glucose in the urine in a normal person, healthy person. Next slide. So in this slide, we can see what usually happens and what we should think about when we do see glucose in the urine. On the x-axis, you can see serum glucose. On the y-axis, you can see excreted glucose milligrams per minute in the urine. And you can see that as serum glucose goes up, you can see that filtered glucose goes up, and the reabsorbed glucose goes up until we hit a serum glucose of about 180. And then above 180, the excreted glucose has gone up because we have hit the maximum level of glucose reabsorption, the maximum level, and that's known as a TM for glucose. Next slide. So what happens, this is another slide showing the exact same thing with, on the x-axis, the plasma glucose, on the y-axis, the glucose filtration rate, and the amount of glucose actually in the urine. That's a misnomer. And you can see normally, as the glucose goes above 180, you have excretion. But if that maximum of glucose, if you affect the transporter, you will start, your TM for glucose will fall, and you'll start to excrete glucose at a glucose of about 100 or 120. And that is always interesting for a nephrologist, for a physician to see when you excrete glucose at in the urine at a normal plasma glucose. And it's known as renal glycosuria. Next slide. What are the causes of renal glycosuria? The ones that come to mind most commonly are the SGLT2 inhibitors, as we heard last week, and they're used therapeutically to help control diabetes and other things. Now, the one that nephrologists will often think about is whether a paraproteinemia is causing the kidney disease if we see renal glycosuria, because that is one that is most commonly seen as another possibility. But as well, heavy metal exposure, which is pretty rare, certain medications, tenofovir, lamivudine, cisplatin, valproate, aminoglycosides can affect the proximal tubule as well. Interstitial nephritis, by affecting all the tubules, can cause renal glycosuria, as well as renal vein thrombosis. Next slide. So in our patient, the differential diagnosis came down to renal vein thrombosis. She had a renal tumor, but in fact, that was ruled out early on because she in fact had a previous CT angio, which did not show renal vein involvement. And in fact, she had a renal vein Doppler, which did not show that. A monoclonal gammopathy, which can cause acute kidney injury and glycosuria, and other causes such as ATN. She got contrast in the remote past, unlikely. Interstitial nephritis from dexlansoprazole or ibuprofen. Next slide. A serum protein electrophoresis was done and did show a paraprotein. Next slide. And the serum protein electrophoresis showed two monoclonal gammopathies with two monoclonal bands in the urine as well, with two bands, a free lambda light chain and an IgG lambda. And hematology was consulted. At this point, I'm going to pass the baton to Dr. Phatak.
Thank you, Marvin. So I'll go back to the protein electrophoresis to point out that, yes, there are two paraproteins, but they're both quite small. One is 0.1 grams, the other is 0.7 grams. And if you look at the immunofixation, it tells you what these are. Although it's the urine, it's likely that the same thing was present in the serum, which is a small band of free lambda light chain and an IgG lambda 0.7 gram paraprotein. So of course, small paraproteins like this are very common. So as people get older, if you're over the age of 60 and you randomly do an SPET on everybody that age, 3 or 4% will have a small monoclonal gammopathy. If it's over the age of 80, that number goes up to something like 10%. So when we're screening older people with protein electrophoresis studies, the probability of incidentally finding a small paraprotein is pretty high. So then the question we're faced with is, what is it? So is it this MGUS or monoclonal gammopathy of unknown significance? We used to call this benign, but we don't call it benign anymore because if you follow these people over time, about 1% of them every year will progress to multiple myeloma. So it's not necessarily benign, but unknown significance. So monoclonal gammopathy of unknown significance is the first thing that comes to mind. Could it be multiple myeloma? Because you've got someone here with kidney failure and anemia. There are some other causes of monoclonal gammopathy, but we don't think those are really relevant to this case. So when do we call something MGUS and not a multiple myeloma? If you're dealing with a non-IgM paraprotein, which is the case here, this was an IgG paraprotein, it needs to be small. The paraprotein level needs to be less than 2 grams. There needs to be less than 1 gram of Bence-Jones proteinuria or light chain protein in the urine. You need to have less than 1 gram. If it's more than that, then it's pretty unlikely that you're dealing with an MGUS. By definition, you need a bone marrow that has less than 10% plasma cells. And you need absence of what we now refer to as CRAB. So the CRAB stands for, the C is hypercalcemia, the R is renal failure, the A is anemia, and the B is bone lesions. So in the absence of those 4 things, with a low plasma cell level and a low paraprotein, you can call it MGUS. In practice, if I have a tiny paraprotein like this and someone doesn't have anemia or renal failure or hypercalcemia or bone involvement, I might not even bother to do a bone marrow exam on them. Might just carefully watch, consider this is MGUS, follow the paraprotein. In this case, she had the renal failure and she had the anemia. So it sort of begged the question, is this MGUS or is it something more than that? And to answer that question, we really needed to first do a bone marrow test. So we did that. And this was her bone marrow. This is the aspirate. If you can see, there are these cells with eccentric nuclei and this deep blue cytoplasm, which are the plasma cells. She does have a few of them, but not a huge number. So this was the bone marrow biopsy, once again showing scattered plasma cells, if you know what you're looking for. I'll make that a little more clear with the immunostain. This is an anti-CD38 stain, which stains the plasma cells. And as you can see, there's this little cluster of plasma cells here. But overall, if you look at the background and you look at the number of plasma cells, we're talking less than 10%. So to go back to our case here, she sort of meets the criteria of a small paraprotein, a low number of plasma cells, However, it's not no crab. She does have renal insufficiency and she does have anemia. So let's focus on that for a second. If renal failure is the only manifestation, about 15 years ago, Merlini and his group sort of made this distinction of if you have lots of plasma cells, then you have bone lesions, anemia, you have crab, then you have multiple myeloma. And you can even have hyperviscosity and direct injury to the kidney, which we call myeloma kidney. However, you can have small M components, which usually do nothing and are MGUS, but sometimes the specific characteristics of the monoclonal protein are such that they result in specific injury to the kidney. And this in particular was referring to amyloidosis. And he called these small, dangerous B cell clones. So they're small clones for all intents and purposes like MGUS, but the nature of the protein somehow damages the kidney. In the last decade or so, this terminology has come into being. We call these monoclonal gammopathies of renal significance. So you have a monoclonal gammopathy, you have nothing else that indicates multiple myeloma, no bony lesions, not many plasma cells in the bone marrow. However, you have renal significance. And what can the renal pathology be? Well, these are entities that the nephrologists know more about than we hematologists do. But you can see light chain amyloidosis. You can see this entity called monoclonal immunoglobulin deposition disease. You can see a proliferative glomerulonephritis with monoclonal immunoglobulin deposits. And you could see these other less common entities, fibrillary glomerulonephritis, immunotactoid glomerulopathy, and light chain proximal nephropathy. Now, to diagnose these in the presence of a monoclonal gammopathy and absence of overt myeloma, you really need a kidney biopsy. The only situation in which you can avoid that is if you have a known diagnosis of light chain amyloid from some other tissue. So you know you have light chain amyloidosis and you can assume the same thing is going on in the kidney, especially if the kidney picture corresponds to that. In this case, not quite, because the glycosuria and so on was not what we would expect with light chain amyloidosis. She could have Fanconi syndrome, but she didn't have all the features of that. So we thought the only way to make a diagnosis of what was causing the renal failure, despite the presence of the monoclonal gammopathy, was to proceed with a kidney biopsy. So this lady had a kidney biopsy, and I'm going to hand back at this point to Dr. Grieff to discuss that.
Thank you, Dr. Phatak. So this is the one picture of the biopsy that is most important. And what you can see, this is a relatively low power view, but you see a lot of blue. And you have a lot of blue there because those are white blood cells. Those are the nuclei of white blood cells. Now you could also see those holes in the kidney, those spaces. Those spaces are tubules. Now, in a normal kidney that doesn't have interstitial nephritis, those tubules are all opposed. They're right next to each other. But that inflammation has closed many of the tubules and has closed them, and you don't see many spaces at all. And that's what's been decreasing, what decreased the kidney function. So she has interstitial inflammation. It's like a rash in the kidney. A bunch of white blood cells have infiltrated the kidney. And in fact, you can see one glomerulus here, which looks quite normal. It's actually the interstitium, the spaces in between the tubules, which is affected in this disease. And she has what we call interstitial nephritis. Next slide. Next slide. Sorry. So I just want to go over the two causes of possible cause of her disease, and then focus on the interstitial nephritis a little bit more. But as Dr. Phatak said, monoclonal gammopathy of renal significance has become a major issue because so many patients have sort of monoclonal gammopathies as we get older, and they may have a cause of kidney disease. And some of them, in fact, have a monoclonal gammopathy of renal significance, where that monoclonal protein just affects the kidneys. Usually a non-malignant B-cell clone. They do not meet the criteria for overt multiple myeloma or a B-cell proliferation, and the hematologic picture is consistent with an MGUS, or monoclonal gammopathy of undetermined significance, but it's affecting the kidney, hence it becomes an MGRS. And this review from 2015 in Kidney International, if any are interested, is excellent and very complete. Next slide.
Can I interject one thing very quickly, Dr. Grieff?
Sure.
So yes, it's true that most of these do not have overt myeloma, because monoclonal gammopathy of unknown significance is so much more common than multiple myeloma. But it's possible in any of these entities for the underlying disease to be multiple myeloma, because it's the nature of the paraprotein that causes the kidney damage. And whether it's myeloma that's making it or less than myeloma that's making it, the kidney damage is the same. So once in a while in these cases, we will actually find overt multiple myeloma.
Thank you.
So just to sort of make that clear. And we always look for it, but it's not always overt, and it's usually MGUS.
Thank you. Super. So the monoclonal gammopathy can affect either cause glomerular disease, often AL amyloidosis, a proliferative glomerulonephritis with monoclonal IgE immunoglobulin deposits, something called C3 glomerulopathy. The interstitial disease, in this case, we were concerned about light chain Fanconi syndrome with glycosuria. Her phosphorus, I think, was also low, and uric acid as well, suggesting a proximal tubular disease. Proximal tubulopathy without crystals, crystal staining histiocytosis. And they do not have light chain cast nephropathy, which is multiple myeloma defining. Next slide. Interstitial nephritis is a very important cause of acute kidney injury. The classical presentation has been rash, eosinophilia, and fever. That's often presented in exams in that way. But clinically, we now see many less symptomatic presentations. And the data is not quite clear, but it appears that there's increasingly recognized in the elderly, and due to the use of non-steroidals and proton pump inhibitors. It's usually drug-induced, and it's become much more common than we think, and sometimes underdiagnosed. There are other causes of interstitial nephritis, such as autoimmune disease, when it can come with uveitis, and IgG4 related disease, drug reaction, sarcoidosis, and other systemic disease. And the treatment is usually drug withdrawal, if drug-induced, as well as steroids. Next slide. At this point, I'm going to pass it to Dr. Godbole to give us some information about the outcome.
Thank you, Dr. Grieff. So as Dr. Grieff mentioned in the previous slide, the treatment for interstitial nephritis is steroids. So our patient as well on discharge was started on a long-term prednisone taper, and atovaquone was added for PJP prophylaxis while being on prednisone. And the paraproteinemia that was noted on the SPEP initially was thought to be due to possible MGUS, and patient was discharged home with possible follow-up. After her discharge, her kidney function completely recovered because of the steroids. She then underwent right-sided nephrectomy, and the pathology of the specimen showed a clear cell renal carcinoma with negative margins, negative lymph nodes, and an interstitial nephritis once again. Next slide. So as we can see here, this is the slide showing us about the clear cell renal carcinoma with its classical presentation of those cells with having clear cytoplasm around them, and it's completely encasing the slide here. Her outpatient labs, which were done after the nephrectomy, were kind of notable for creatinine of 1.91, which coincides with having a single kidney. And all her other lab work, including the bicarbonate and the electrolytes, were normal. So on this note, I would like to thank Dr. Phatak and Dr. Grieff for supporting me through this presentation and being a part of it. And of course, last but not the least, I want to thank Dr. Silver and the entire RGH family for whatever we all are doing in COVID situation and being strong and united together. Thank you, everyone.
So I'm going to ask Dr. Grieff the first question here. So this patient had interstitial nephritis. What do you think was the cause of that, and how do you put the case together now, looking back?
I think the cause was either due to the nonsteroidals or due to the proton pump inhibitors. My suspicion it was due to the proton pump inhibitors. We're seeing more and more cases of PPI-induced interstitial nephritis. And it's becoming a big issue. In fact, we see many complications of PPIs, including hypomagnesemia. And there is some data that it increases the risk of ESRD in the population. It certainly could also be the nonsteroidal. Usually nonsteroidal anti-inflammatory drug-induced interstitial nephritis has a lot of proteinuria, but it's hard to tell which one it was. I suspect it's more likely the PPI that caused her acute kidney injury.
So there's a question from an anonymous attendee that says, why not just do a nephrectomy for the mass? Why bother with a kidney biopsy? Well, the issue was she had acute renal failure. So she had had a creatinine that had jumped from 1 to 4.7. And doing a nephrectomy in that circumstance would have left her on dialysis. And because that renal failure was acute, we felt strongly that knowing the etiology of it and fixing the renal failure was important before taking out one kidney. So that's why the sequence. She had a kidney biopsy that showed the interstitial nephritis. We treated the acute renal insufficiency with steroids. She got better, and that's when she could safely have her kidney mass removed. So I think some of these were answered. So someone asked, so we do not think this patient had MGRS. That's correct. She did not have any of the forms of MGRS that we discussed. The monoclonal gammopathy, in retrospect, was an incidental finding. She likely had interstitial nephritis related to drug, as Dr. Grieff pointed out, and she got better with steroids. What did the EM and immunofluorescence show, if not the biopsy on the nephrectomy specimen?
Immunofluorescence didn't show any monoclonality. I can't remember what the EM showed, actually, but I think it was also negative as well.
Right, so everything was negative except the interstitial nephritis. Yeah, and on the nephrectomy biopsy, there was the clear cell tumor, but then in the background, there was still interstitial nephritis. So what is the timing of the interstitial nephritis related to the PPI?
That's actually, so I'm not sure how long she had been on the PPI. It was several, that's not clear from the chart, actually. That's a good question. But some of them could be on the PPI for 2 to 3 months, actually, if you take a look at some of the literature. So you could be on the PPI a very long time before you actually see the acute kidney injury. It's not just typical, like 2 weeks. Like an antibiotic you may get after a few weeks. But the PPI, some of the cases have been they've been on it for a while actually before they get the acute kidney injury.
Okay. So I have a question for Dr. Alag actually. It's Dr. Sham who asks, can we opt out of some of the changes? Because some of the changes in the EMR have been very difficult.
Yeah, I'm in touch with him and Saad on email on the issues in particular. So most of the changes, usually every change which is either requested by us or proposed by Epic is reviewed at advisory groups. Certain changes which are like structural changes or software changes are from Epic where we have to adapt just like you're updating Microsoft or your Apple phones or you just update them. Yeah. You can provide feedback to the main manufacturer, but there's not much say. You can always provide feedback later and be part of the designing process in the beginning. But yes, those issues which happen with the upgrade, I have the list of those. and we'll work on those. That's happening on the sidebar.
So I did tape this recording. Somebody else asked if the slides will be distributed. So there'll be a YouTube video of this Grand Rounds that will be ready by this evening, which will include both parts. So if someone wants to go back and look at the EMR part or look at our discussion of the case, it will be there. And I think with that, any other comments from Dr. Grieff or Godbole or Alag? We have 2 more minutes.
Yeah, I'll forward my slides to Lisa so she can distribute it accordingly with the YouTube video.
Thank you.
Fantastic. So thank you, everyone. And next week, the plan is to come back to a COVID theme. And the plan actually is to have 7 or 8 different physicians talk about how their life as physicians has changed in the age of COVID. So it'll be a different kind of Grand Rounds. I hope to also have some data in the beginning, but then I want to have these different points of view on how COVID is changing our medical practice, but also changing our personal lives and how we, the major impact it's had on us overall. So I think it should be an interesting discussion. Please join and see you next week.